Chapter 25, Trauma Overview. The National EMS Education Standard Competencies for this chapter applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. So the focus is going to be on trauma. And trauma requires fundamental knowledge. You must have a foundational knowledge of the system that is being affected, and you must know how to manage whatever injuries are presented and the proper way to package and transport the patient. We'll be looking at pathophysiology, assessment, and management of trauma patient. We'll look at trauma scoring, rapid transport, and destination issues, and specific modes for transportation. We'll be looking at multi-system trauma, recognition and management of multi-system trauma patients with multiple injuries. We'll look at the pathophysiology, assessment and management of multi-system trauma, and the blast injuries. Introduction. For people younger than age 44, traumatic injuries are the leading cause of death in the United States. The statistics might be similar here in Jamaica. Traumatic emergencies occur as a result of physical forces applied to the body, and medical emergencies occur from an illness or condition not caused by an outside force. We need to have an index of suspicion. The mechanism of injury is what caused the injury to the patient. The index of suspicion is you thinking about what is the worst injury the patient could have as a result of the mechanism. So the index of suspicion is your awareness and concern for potential serious underlying and unseen injuries. Where is my slide? Oh, hold on. Energy and trauma. Traumatic injury occurs when the body tissues are exposed to energy levels beyond their tolerance. The mechanism of injury is the way traumatic injuries occur. It describes forces acting on the body that cause injury. And we have discussed this previously. So trauma is caused from forces applied to the body. When the body is unable to dissipate these forces, the force becomes concentrated and it results in soft tissue injury or trauma. Whatever caused the trauma is referred to as the mechanism of injury. The index of suspicion is the most serious injury you're expecting based on what caused the injury. Now, we need to understand three concepts of energy: potential energy, kinetic energy, and the energy of work. Now, if I have a pencil in my hand and I am about to let that pencil go or drop the pencil on the ground, the pencil has what is called potential energy. So everything has potential energy. It is the energy that an object possesses before a fall. So if I have the pencil between my fingers and I'm about to release it, that's potential energy. When I release the pencil, when it starts to travel, it becomes kinetic energy. That's energy in motion or movement. When the pencil hits the ground, what stops its movement is referred to as the energy of work. So again, potential energy is energy that an object possesses before a fall. Kinetic energy is energy in motion. And energy of work is what stops the motion. Energy, the other concept of energy that you need to understand is that energy cannot be created. So we cannot create energy and it cannot be destroyed. It can only be converted or transformed. And we went through that with the three concepts of energy. The pencil, before it was released from my fingers, it was potential energy. When it is released from my fingers, it becomes kinetic energy when it's moving. And when it hits the ground, that's the energy of work. Now, the other concept of energy that you need to understand, it's based on Newton's law. An object in motion will remain in motion until it is acted upon by an equal or opposite force. So you need to understand that concept. An object in motion will remain in motion until it is acted upon by an equal or opposite force. And energy is force times acceleration or deceleration. That's what energy is. Force times acceleration or deceleration. Work is force acting over a distance. Forces that bend, pull, or compress tissues beyond their inherent limits result in the work that cause injury. Kinetic energy is the energy of a moving object. And the formula for that is Ke equal half mass times velocity squared. You don't need to remember this formula. What you need to understand based on the formula is that the size of the object is not that significant in comparison to the speed or movement. So velocity greatly influences kinetic energy, not the size or mass of the object. Speed has more influence over kinetic energy. That's what you need to remember. Potential energy is a product of mass, force of gravity, and height, mostly associated with the energy of falling objects. The mechanism of injury profiles. Different MOIs produce many types of injuries. Non-significant injuries include injury to an isolated body part, fall without the loss of consciousness. Anytime you focus on the mechanism of injury, you need to determine if it's a diffuse mechanism or a localized mechanism. Localized mechanisms will cause what we refer to as non-significant injuries. Diffuse mechanisms will cause significant injuries or multi-system trauma. Significant injuries. Injury to more than one body system, multi-system trauma, falls from heights, and 3 times a person's height is, an adult height is considered significant. If they fall from a standing position and lose consciousness, that is considered significant. For a pediatric patient, it is 2.5 times their height. And if they fall from a standing position and they are unresponsive, that's considered significant. Motor vehicle and motorcycle crashes, car versus pedestrian or bicycle, gunshot wounds, stabbings. These are significant injuries. Now, the two main type of trauma that we will be looking at in this chapter, there can be others, but these are the main ones that we'll be focusing on. Blunt and penetrating trauma. Blunt trauma is the result of force to the body that causes injury without penetrating the soft tissues. Penetrating trauma causes injury by objects that pierce and penetrate the surface of the body. Either type may occur from a variety of mechanisms. Blunt trauma results from an object making contact with the body. Motor vehicle crashes and falls are the most common MOIs. Be alert to skin discoloration and pain. Maintain a high index of suspicion for hidden injuries. And ensure that you understand the difference between index of suspicion and the mechanism of injury. Mechanism of injury is what caused the injury to the patient. The index of suspicion is you thinking about what is the worst complication or injury the patient can have based on the MOI. Now, let's look at vehicular crashes or motor vehicle accidents. Now, there are different types of motor vehicle accidents or crashes. But within these motor vehicle accidents, there are three main collisions that will occur. And it comes back to the principle that I mentioned earlier. An object will remain in motion, right, until it is acted upon by an equal or opposite force. So there are three collisions that occur in a motor vehicle accident, regardless of the type of motor vehicle accident. The first one is the car against another object. So the car is traveling at 120 miles per hour and hits a light post. The car hitting the light post is the first collision. The second collision is the person inside the vehicle. So when the car hits a light post at 120 miles per hour or kilometers per hour and comes to a sudden stop, the person inside the vehicle is still moving. An object in motion will remain in motion until it is acted upon by an equal or opposite force. So the person inside the vehicle is still moving at 120 kilometers an hour. Then that patient hits the interior of the vehicle, or that person hits the interior of the vehicle at 120 kilometers. That's the second collision. So the second collision is when the patient or the person that's operating the vehicle hits the interior of the vehicle. That's the second collision. The third collision is the organs within the body. So when the person inside the vehicle hits the vehicle at 120 kilometers, the organs inside of the body is still moving at 120 kilometers. Then the organs will hit the interior of the body and come to a stop. So that's the three collisions. First one, car hits an object, comes to a stop. Whatever speed the car was traveling at, that speed will be transferred to the patient. The patient is traveling at the same speed, hits the interior of the car. That's the second collision. Third collision is the organs are still traveling at the same speed, and then they hit the interior of the body. So that's the 3 collisions that occur regardless of the type of motor vehicle accident. Now, it is not something for you to SWAT. These are concepts that you need to understand. So do not SWAT that the first collision is the car hitting an object, and the second is the patient hitting the interior of the vehicle, and the third is the organs hitting the inside of the body or interior of the body. You need to understand what it means. Now, the first collision, when I'm thinking about the first collision, I am thinking about access to the patient. So when I look at a car hitting a light post and come to a stop, when I'm thinking about the vehicle hitting the light post, I'm thinking about access to the patient. When I look on the interior of the car to look for damage to the interior of the car, that's the second collision. So when I look at the interior of the car, I'm looking to see what is deformed in the interior of the car and which part of the patient deformed that area of the vehicle. Was it their head? Was it their knee? Was it their chest? So when I'm thinking about the second collision, which is a patient hitting the interior of a vehicle, I'm thinking about physical injuries, injuries I can see, external injuries to the patient. That's my thought process. When I start to look on the patient for impact points on the patient, so when I start to look at the patient for impact points, I'm thinking about the third collision. So I'm looking to see if there's bruising to the head, the neck, the chest, the arms, any part of the patient's body. And when I look for impact points on the patient, I'm thinking about what is underneath that structure. So when you think about the third collision, you're thinking about internal injuries to your patient. That is understanding. So the first collision is access. We're thinking about access to the patient. The second collision, we're thinking about external injuries to the patient. And the third collision, we're thinking about internal injuries to the patient. So that's your 3 collisions. So a crash consists of 3 collisions. Car against another car, tree or object would be the first one. By assessing the vehicle, you can often determine the MOI. The second collision is a passenger against the interior of the car. Common passenger injuries include lower extremity fractures, flail chest, and head trauma. And the third collision is the passenger's internal organs against solid structures of the body. Internal injuries may not be as obvious as external injuries, but are often the most life-threatening. And the injury depicted in the picture is coup contra coup. It shows that the anterior and posterior portion of the brain has been injured. So when the head went forward and hit the windshield, that caused injury to the anterior portion of the brain. When the head goes back and hit a headrest or whatever is behind the patient, then the posterior portion of the brain is injured. Coup contra coup, that's what that injury is called. Still on vehicular crashes, significant MOIs include the following findings: death of an occupant in the vehicle, severe deformity of the vehicle or intrusion into the vehicle, severe damage from the rear, crashes in which rotation is involved, and ejection from the vehicle. Now let's look at the different types of motor vehicle crashes. First one is frontal crashes. Evaluate supplemental restraint system. Determine whether the passenger was restrained and whether the airbags deployed. Seat belts and airbags are effective in preventing a second collision inside the motor vehicle. Airbags decrease the severity of deceleration injuries and decrease injury to the chest, face, and head. Now, in front, majority of motor vehicle crashes are caused from deceleration forces. The only one that is caused from acceleration is rear end collision. Now, with frontal collisions, patients that are tall tend to go over the steering. So patients that are tall will go over the steering or dashboard and their head might hit the windshield. Their chest can deform the dashboard or it can deform the steering wheel. So look for deformity in the upper portion of the steering wheel and the lower portion. Upper can be upper chest or chest. If it's deformed on the lower end, it can be abdominal. Can also be chest as well. The knees can deform dashboards. So these are things you should be thinking about. Persons that are short tend to go under the steering wheel or dashboard. Now, despite airbags, suspect injuries to extremities resulting from the second collision. And the second collision is external injuries. Internal organs can also be damaged, resulting from third collision. Third collision is internal injuries. Children shorter than 4 feet 9 should ride in the rear seat. Remember that if the airbag did not inflate during the accident, it may deploy during extrication. Remember that supplemental restraint systems can cause harm whether they are used properly or improperly. Look for contact points between the patient and the vehicle as you perform a simple, quick evaluation of the interior of the vehicle. Now, rear end. And as I stated previously, rear end crashes is the only crashes that result from acceleration forces. And this is the motor vehicle crash that is commonly associated with whiplash type injuries, particularly in the absence of a headrest or if the headrest is not positioned properly. As the body is propelled forward, the head and neck are left behind. Acceleration type injury to the brain is possible. Lateral crashes now. These are side impacts. It is very, very common. It is a very common cause of death, and usually the cause of death associated with lateral crashes is a torn aorta or shearing of the aorta. So lateral crashes are commonly associated with shearing of the aorta, which can result in the patient's bleeding to death. It can also be associated with lateral type whiplash injuries to the neck. A vehicle struck from the side is usually struck above its center of gravity it begins to rock away from the side of impact, and it results in the passenger sustaining a lateral whiplash injury. If substantial intrusion into the passenger compartment, suspect a lateral chest and abdomen injuries on the side of the impact. So look for injuries to the chest and abdomen on the side associated with the impact. It's possible for them to have lower extremity fractures, pelvic issues or pelvic injuries, and they can have rib injuries. And of course, they can have internal damage. So they can have organ damage from third collision. Now, rollover crashes. Rollover crashes and rotational crashes are the most severe motor vehicle crashes. And the reason for that is these are crashes that multiply the 3 collisions. So rollover crashes multiplies the 3 collision. Every time it rolls, 3 collisions will occur. So it multiplies the 3 collisions. So rollover crashes. Large trucks and sport utility vehicles are prone to rollovers. Injuries depend on whether the passenger was restrained. Most common life-threatening event is ejection or partial ejection of the passenger from the vehicle. Rotational crashes. They are similar to rollovers. They multiply the 3 collisions. So spins are conceptually similar to rollovers. Rotation of the vehicle provides opportunities for the vehicle to strike objects such as utility poles. And that would be your motor vehicle crashes. Now let's look at car versus pedestrian. Car always win. Injuries are often graphic and apparent. Can also be serious unseen injuries. You should determine the speed of the vehicle, if possible, whether the patient was thrown through the ear, the surface the patient landed on, whether the patient was struck and pulled under the vehicle. These are things that should be considered. Evaluate the vehicle that struck the patient for structural damage. ALS backup should be summoned for any patients who have sustained a significant MOI. And that would be your car versus pedestrian. Let's look at car versus bicycle. Evaluate like you would for a car versus pedestrian. Car always win. Evaluate the damage to and the position of the bicycle. If the patient was wearing a helmet, inspect it for damage. Presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise at the hospital. Spinal stabilization must be initiated and maintained during the encounter. Car versus motorcycle. Protection is from helmet. So if the rider is wearing a helmet, that can protect them. Leather or abrasion resistant clothing can also provide protection, and boots. When assessing the scene of a car versus a motorcycle, look for deformity of the motorcycle, side of most damage, distance of skid in the road, deformity of stationary objects or other vehicles, extent and location of deformity in the helmet. Now, different types of motorcycle crashes. You have head-on crashes. Motorcycle strikes another object and stops its forward motion while the rider continues to move forward. or continues moving forward. That motion can snap the femur, so they can have bilateral femur fractures from that movement. Angular crashes, motorcycle strikes an object at an angle so that the rider sustains direct crushing injuries to the lower extremities. So angular crashes are associated with crush type injuries. Ejection. The rider will travel at high speed until stopped by a stationary object, another vehicle, or a road drag. An object in motion will remain in motion until it is acted upon by an equal or opposite force. Then you have the control crash. So some persons are trained or have training in separating themselves from the motorcycle when it's about to crash. Sometimes it's not done very well. So a control crash technique used to separate the rider from the body of the motorcycle. So sometimes they get trapped and they are dragged along the road surface until the motorcycle hits an object, a stationary object. Might be a moving object that it hit as well. Now let's look at falls. Now, when we think about falls, we need to consider the height that the patient fell from, whether or not they hit anything prior to reaching the ground, or that's important. We need to think about the type of surface that they fell on, and we need to consider the body part that hit that surface. So falls, injury potential depends on the height from which a patient fell. More than 20 feet, 6 meters is considered significant. Internal injuries pose the greatest threat to life. Patients who fall and land on their feet may have less severe internal injuries. Their legs may have absorbed much of the energy of the fall, but it don't mean that they can't have internal injuries, because the force can be transferred from the heel up towards the pelvic region and the spinal cord. Take the following factors into account when thinking about a fall: the height of the fall. And remember, more than 20 feet or 6 meters is considered significant. 3 times a person's height, adult, is significant. 1.5 times a pediatric height is considered significant. A patient that falls from a standing position that is not responding is considered significant. So the height of the fall, the type of surface struck, and the part of the body that hit first, followed by the path of energy displacement. So think about which body part hit the surface and consider whether or not the energy was transferred to somewhere else in the body. Now, penetrating trauma. This is the second leading cause of trauma death after blunt trauma. It can be accidentally by impalement, or it can be intentionally by a knife, ice pick, or other weapon. Penetrating trauma. Now, penetrating trauma can be from low energy, can be from medium energy, and it can be from high energy. Now, low energy is usually associated with stabbing objects like knives, ice pick. These can be considered low energy. With low energy penetrations, injuries are caused by the sharp edges of the object moving through the body. Knives may have been deliberately moved around internally, causing more damage than the external wound suggests. And if the blade goes in and up, you need to think about injuries to where it went in and injuries to where it went up. So sometimes the stab is in and up. So think about that. And there's a saying in EMS, if you suspect an injury to the abdomen, you should consider an injury to the chest. Chest is abdomen, abdomen is chest. Now, the path of the projectile may not be easy to predict. Bullet may ricochet within the body before exiting. Path the projectile takes is its trajectory, and fragmentation will increase damage. And all of this is associated with bullets. Now, cavitation results from rapid changes in tissue and fluid pressure that occur with the passage of the projectile. So let me just back up a little bit. Now, we understand that low energy can be associated with stabbing objects. Medium energy can be associated with handguns. And yes, I'm aware that there are some handguns that can have high energy, but let's keep it simple. So medium energy is associated with handguns, and the nozzle of the handgun, it has serration, so circles, think of it as circle, right? And when the bullet is fired, it spins. So when it exits the handgun, it is spinning as it travels. When it spins, a pressure wave is created around the bullet. And that pressure wave that is created is depicted in this diagram. So that outside area, the outside area where you see temporary cavity is the pressure wave. The pressure wave creates what we call a temporary cavity. And the actual path that the bullet takes is the permanent cavity. So ensure that you understand that. So you have temporary cavitation and you have permanent cavitation. Temporary is from the pressure wave that's created as the bullet spins or travels. The permanent cavity is the path that the bullet takes, the actual path. So cavitation results from rapid changes in tissue and fluid pressure that occur with the passage of the projectile. Can result in serious injury to internal organs. So handguns would be considered medium energy. High energy would be associated with shotguns and rifles. Now, the relationship between distance and the severity of injury varies depending on the type of weapon involved. Air resistance or drag slows the projectile. Area damaged by projectiles is typically larger than the diameter of the projectile. So with gunshot wounds, where the bullet enters that wound is usually smaller than the exit wound where it comes out. And it's because of the cavitation, the permanent cavitation, because the bullet is pulling tissue as it travels. So wherever it comes out, it's gonna have a larger wound there. Energy available for a bullet to cause damage is more of a function of its speed than its mass. We learned this earlier. Kinetic energy is half mass times velocity squared. Velocity greatly influences energy. So the speed that the bullet is traveling is far more severe in terms of how it affects energy than the size or mass of the bullet. All right, so this table 225-1, recognizing developing problems in trauma patients. You can have a look at that when you're going through your PowerPoints or your textbook. Now, blast injuries, most common in military conflict, but it is now being seen in mines, shipyards, chemical plants, and terrorist attacks. And there are 4 stages of a blast injury. You have the primary blast injury, and this is injuries due to the blast wave. So injuries created from the wave. And a blast is when a solid, liquid, or gas is rapidly heated and it expands. That's what it creates an explosion. When a solid, liquid or gas or fluid is rapidly heated and it expands or explodes. The primary blast is from the wave. There's a pressure wave that is created from the blast, and that can cause injuries. The secondary blast injury is due to missiles being propelled by the blast force. So these are objects that are pushed by the blast, shrapnel, things that travel as a result of the blast and end up in the patient. The tertiary blast is due to impact with another object. So the blast occurs and the person is thrown against a wall and receive injuries as a result of it. That's the tertiary blast. The quaternary blast injury is usually miscellaneous. These are injuries associated with burns, toxic gases, building collapse, miscellaneous stuff. So the primary blast injuries are due entirely to the blast itself. That's a pressure wave. So damage occurs to the body as a result of the pressure wave. The secondary blast injuries are a result of damage to the body, which results from the body being struck by flying debris or shrapnel. Tertiary blast injury, the victim, this is the patient. The victim is hurled by the force of the explosion. Quaternary blast or miscellaneous blast injuries. These are burns from hot gases or fires started by the blast, respiratory injury from inhaling toxic gases, and crush injury from the collapse of buildings. Most patients will have some combination of the 4 types of injuries. Organs that contain ear are most susceptible to pressure changes. So the middle of the ear, the lung, the gastrointestinal tract, these are areas that can be affected by pressure waves from a blast. The ear is most sensitive to blast injuries. Pulmonary blast injuries result from short-range exposure to detonation of explosives. Arterial ear embolisms can produce disturbances in vision, change in behavior and state of consciousness, and a variety of other neurologic signs. And an embolism is simply a clot that travels. That's what an embolus is, a clot that travels. Solid organs are relatively protected from shockwave injury. Neurologic injuries and head trauma are the most common causes of death traumatic amputations are common. Multi-system trauma. Multi-system trauma involves more than one body system. Can be head and spinal trauma. It can be chest and abdominal trauma, and it can be chest and multiple extremity trauma. Alert medical control and transport rapidly. Patients have a high level of morbidity and mortality. So the patient prognosis when they have multiple trauma is very poor. Time matters for these patients. Now, the golden principles of pre-hospital trauma care. Your main priority is to ensure your safety, safety of your crew, safety of the patient. Determine the need for additional personnel or equipment. Evaluate the MOI. Identify and manage life threats. Then focus on patient care. And that should be directed towards hemorrhage control, airway and ventilatory support, treating for shock, spinal immobilization, or spinal motion restriction. Transport immediately to the appropriate facility. Definitive care requires surgical intervention. Very important statement. So for a critically injured trauma patient, definitive care, what is going to save them is surgical intervention. We can't do that unseen. So unseen time should be limited to 10 minutes or less. 6 minutes for your primary assessment, and within 10 minutes, that patient should be packaged and ready to go. Obtain a sample history and complete a secondary assessment. Consider ALS intercept or ear medical transportation. Now, patient assessment. When a patient has experienced a significant MOI and is critical and is in critical condition, rapidly perform a physical examination. When a patient has experienced a non-significant MOI, focus on the chief complaint. We've had this discussion already. If the MOI is significant, it is LOC, airway, breathing, circulation, rapid scan. Consider GCS, load and go. Once you package the patient, if the patient is talking, history, then vitals. If the patient not talking, vitals, consider physical findings. If the MOI is non-significant, then it's LOC, airway, breathing, circulation. Assess and manage these areas. Consider the patient's GCS and focus on the area where the injury is. Stabilize, package your patient, sample vital signs, continue to monitor your patient and route to the most appropriate facility. Injuries to the head. Disability and unseen injury to the brain may occur. Bleeding or swelling inside the skull is often life-threatening. Include frequent neurologic examination in your assessment. So if you suspect a head injury, neurologic assessment must be done often. Some patients will not have obvious signs or symptoms. Injuries to neck and throat. Area of serious or deadly injuries. Airway problems may result. Look for decap BTLS in the neck region. Swelling may prevent blood flow to the brain. Penetrating injury may result in ear embolism. Crushing injury may cause cartilages of the upper airway and larynx to fracture. Injuries to the chest. The chest contains the heart, lungs, and large blood vessels. Many life-threatening injuries may occur. They can have broken ribs, which may affect their ability to breathe. They can have damage to the heart. The heart can be bruised, or it can have a heart contusion. Large vessels may be torn, the aorta, the vena cava. These are large vessels. A penetration or perforation of integrity of the chest is called an open chest wound. If this is not treated, shock or death will result. Assess the chest region every 5 minutes. Assessment should include decap BTLS. Lung sounds are a must, and observe the patient chest rise and fall. Once you suspect that a ventilation issue is present, you need to start breathing for that patient. Injuries to the abdomen. The abdomen contains vital organs that require a very high amount of blood flow. Solid organs include the liver, spleen, pancreas, and kidneys. These organs are highly vascular, so they can bleed severely if damaged. Hollow organs include the stomach, large and small intestines, and the urinary bladder. The hollow organs will spill their contents, which causes irritation. And if it's in the abdominal area, can cause peritonitis. Solid organs may tear, lacerate, or fracture. Hollow organs may rupture and leak toxic digestive chemicals. The rupture of large blood vessels can cause serious unseen bleeding. Now, management, transportation, and destination. Scene time. Survival of critically injured trauma patients is time dependent. Time is important. Limit unseen time to less than 10 minutes. That's your goal. Critically injured patient, dangerous MOI, decreased level of consciousness, threats to airway, breathing, or circulation. Destination selection. So in the States, you have level 1, level 2, level 3, and level 4 facilities. The level 1 and level 2 can deal with any type of patients, right? So level 1 and level 2 can deal with any type of patient. So the level 1 or level 2 facility is the same. Difference between a level 1 and level 2 facility is a level 1 facility is also a teaching hospital, right? So a level 1 have every specialty available, but it also has students. It's a teaching hospital. Level 2 have all the specialties available, but it is not a teaching hospital. A level 3 facility has the specialties, but they are not at the hospital. They would have to request that they come in. So they have to call them or page them to come in for a particular call. That's a level 3 facility. A level 4 facility can only perform ALS skills. They can't go outside of that. So there's no special care available at a level 4 facility. So destination selection. Level 1 facility serves large cities or heavily populated areas. It provides every aspect of trauma care, usually university-based hospitals. Level 2 facility, located in less population-dense areas, provides initial definitive care. Level 3 facility provides assessment, resuscitation, emergency care, and stabilization, and transfer patients to level 1 or level 2 facility when necessary. A level 4 facility is found in remote outlying areas and provides advanced trauma life support. So they can only do what ALS does at a level 4 facility. Now, in Jamaica, you have to be familiar with the healthcare facilities within your primary service area, and you need to know the capabilities of these healthcare facilities, right? And use your judgment at that point. So for instance, if there was a serious motor vehicle accident in Halfway Tree at where NCB is, across from the pharmacy, the nearest hospital would be Medical Associates, but Medical Associate doesn't have the resources or capabilities to deal with a serious trauma patient. So if you took that patient to Medical Associates, they would eventually have to transfer the patient to UE. So it's better you take that patient to UE where they have the capabilities and resources to deal with a critical trauma patient. So you need to be familiar with the healthcare facilities within your primary service area. Now, AAMS and Medivac Foundation internationally identified criteria for emergency ear medical services for trauma patients. Now, things that we need to consider to request Medivac. Extended period required to access or extricate a remote or trapped patient, meaning we're on the scene long to get access and remove the patient from the scene or vehicle. Patient needs ALS care and no ALS level ground ambulance services available. Patient has multiple trauma or there is a mass casualty incident. Trauma centers are categorized as either adult trauma centers or pediatric trauma centers. Do not transport a pediatric patient to an adult trauma center when a pediatric trauma center is available. Now, type of transport. You have ground EMS units, which are staffed by EMTs and paramedics. You have air EMS units or critical care transport units, which are staffed by critical care nurses and paramedics. And in some systems, they have respiratory therapists or they have doctors on the critical care transport. Now, special considerations. It's very important to remain calm. That is something that you will develop over time. So the more calls you go on, the more relaxed you'll be when you're dealing with situations. And when I say calls that you go on, I'm talking about serious calls. I'm not talking about routine transports. So the more trauma you see, the more relaxed you'll be in approaching the scene. It's very important to remain calm. If you're not calm, you're unable to think clearly and you're gonna be wasting precious time because you're all over the place. When you're calm, you're able to sequentially process what's happening and do what is appropriate for the patient. But it comes with experience. Complete an organized assessment, correct life-threatening injuries, do no harm, never hesitate to contact ALS backup or medical control for guidance. And that would be the end of this chapter.